Hi guys, welcome back. So I apologize in advance because I'm not feeling very well. So I might sneeze and I might have to wipe my nose every now and then. But we'll get through this lecture, we'll get through this video together. So today we're gonna discuss COPD. So COPD is chronic obstructive pulmonary disease. And this consists of two different diseases. So we have chronic bronchitis and we have emphysema. So with COPD, it's not usually very clear cut, so we might see symptoms of both chronic bronchitis and emphysema happening in one patient, okay? So that's very important. I want you to remember that. So let's first discuss the risk factors and some of the potential causes of COPD. So the majority of COPD cases is caused by smoking. So smoking is the biggest cause of COPD. It causes like 90 to 95% of the cases. And I'll explain why in a bit. So the next one can be inhalation of dust, silica, or even just air pollutants. The third one, which is a genetic cause, it's actually an autosomal dominant genetic condition. And it's called alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is made by the liver, and the deficiency of this particular chemical can lead to the development of COPD. So now I want to discuss the pathophysiology first, so how we develop chronic bronchitis and emphysema from these causes that I've just mentioned. So let's start with chronic bronchitis. So with chronic bronchitis, I want you to remember mucus buildup. Okay, so chronic bronchitis is all about mucus buildup. So because of these irritants, whether that's smoke, dust, silica, air pollutants, what they do when they get to our airways is that they irritate our submucosal glands. Recall that our submucosal glands, they produce mucus, and this is in a physiological setting. Even without these irritants, our submucosal glands, they produce mucus. And mucus is important to humidify the airway, to keep the airways moist, and to trap any pathogens in the airway so that we can get rid of it, okay? But because of this irritant, those submucosal glands, they get very, very irritated. So they start significantly increasing the production of mucus. And they do this via two mechanisms. So they get bigger in size and they increase in number. So what we see, because of these irritants, we see the hyperplasia and the hypertrophy of submucosal glands. Okay, so hyperplasia is the increase in numbers, and hypertrophy is the increase in size of these submucosal glands, significantly increasing mucus production and therefore narrowing our airways. If you produce more mucus, they just, they stay in their airways. They make the lumen of the airways narrower. We also have specialized cells called goblet cells, and these cells too get irritated. They also produce mucus, and when they get irritated, they just jack up the production of mucus. They just produce more and more mucus. The next thing that happens, some of the cells, they have cilia, right? And the cilia is important to help us clear the mucus, Because of these irritants, the cilia, they get destroyed. So what we have, they get shortened, they get destroyed. So what we have is ciliary dysfunction. So now those cilia, they're not working properly. So it's even harder for us. Not just we have lots more mucus. Now it's even harder for us to clear out that mucus from our airways. So now we can have like mucus plugging. And if we can't clear that mucus out, we can cause obstruction in the airway. Because of this mucus plugging and the fact that we're creating an obstruction in the airway because the mucus is just stuck there, what happens is that we can't get as much oxygen in, and even more significantly, we can't get a lot of CO2 out. So imagine this is an airway and this is a mucus plug. So during inspiration, look, because I've significantly narrowed that lumen, I'm not going to get a lot of oxygen into my airway. And during expiration, our airway, they actually gets a little bit narrower during expiration compared to inhalation, and therefore we significantly decrease the amount of CO2 that we can exhale out, okay? And this causes air trapping, which is an important hallmark of COPD. So because we can't get as much oxygen in, we get hypoxemia, low partial pressures of oxygen in the blood. And because we can't get a lot of our CO2 back out, we get hypercapnia, which is the increase of partial pressure of CO2 in our bloodstream, okay? So we get hypoxemia and we get hypercapnia. Also, what happens, because we have the cilia that's destroyed and we're not clearing out the mucus with the pathogens and things, this puts us at a very increased risk of developing infections in our lungs. For instance, maybe pneumonia. So these are the problems that happen, or this is how chronic bronchitis develops. Now let's move on to the pathophysiology of emphysema. With emphysema, I want you to remember that it's a structural problem, okay? As opposed to chronic bronchitis, which is all about mucus buildup and mucus plugging. In emphysema, we have like structural issues going on. So, okay, in a normal physiological setting, we have alveolar macrophages. We have macrophages in our alveoli. They just stay there because when they find any like pathogens or particles that shouldn't be there, what they do is they engulf that pathogen or that particle. And when they undergo phagocytosis, when they engulf that, they release cytokines, which then call on to other white blood cells like neutrophils and more macrophages. And these guys, what they do is that they secrete proteases, like for instance collagenase and elastase. So collagenase obviously breaks down collagen, elastase breaks down elastin. And elastin in their airways, it's very important. It has two functions, very, very important. So the first function of elastin is that they help with the recoil of the alveoli to help us expel the air during expiration. So you know that expiration is a passive process. We don't actually have to do anything because the the alveoli, they just recoil, you know, to help us expel the air out. And partly that's, you know, elastin helps us to do that. But at the same time, elastin also helps us to keep those airways open during expiration when we have a low pressure in that airway, in that tube, okay? So again, elastin helps us with the recoil to help us expel air out during expiration, and at the same time it helps us keep those airways patent, open during expiration when the pressure inside that system is low, to prevent the collapse of the airway during expiration. Now you might be thinking that if this is a physiological process, then surely it should be very damaging to the alveoli and to the airways to have these proteases, this elastase, to just be roaming around, just degrading proteins and degrading elastin. Well, you're right, but this is where alpha-1 antitrypsin comes into play. So alpha-1 antitrypsin, what is produced by the liver, and what it does is it actually inhibits elastase, okay? So it prevents that kind of collateral damage because of the immune response, that just a normal immune response. So now you can imagine if we have alpha-1 antitrypsin deficiency. If we have alpha-1 antitrypsin deficiency, we don't have alpha-1 antitrypsin now to inhibit these elastase. So now they can just go around and break down elastin as much as they want, which then causes some of the problems that we see in emphysema. Now let's talk about what happens because of these pollutants and these smoke, what that does that leads to emphysema. Okay, now because we have these irritants in the lung, we obviously heighten the immune response. We activate these macrophages even more. They release more cytokines. They call more neutrophils and macrophages, releasing these proteases, especially elastase, breaking down the elastin. So the first few things that happen is that we break down the elastic tissue, meaning that it's even harder for us to recoil and help us expel the air out. So it's gonna be difficult to expel air out during expiration, and also the second thing is it's gonna be difficult for us to maintain that airway patent during expiration, during that time when it has low pressure, because we've destroyed the elastic tissue. So now what happens when we try expire, when we try exhale, that airway, it just collapses. So now you can imagine, I mean, during inspiration, it stays open. So we take, you know, oxygen and air in, but during expiration, we don't recoil so much, so, you know, we don't expel so much air out. And when we expel air out, the airways collapse. So now it's preventing us from being able to expel as much air out. And this leads to air trapping. So we trap a lot of air and a lot of CO2 inside the lung. The loss of elastic tissue also affects the lung as a whole. So because we degrade a lot of those elastin, what happens is that the lung becomes hyper compliant. So now every time we take a breath in, when we do inhalation, the lungs just expand, you know, it expands so much because it's hyper compliant. But then when it comes to expiration, we can't expel a lot of that air out. So this causes a lot of air trapping and the dilation of our lungs. The loss and the degradation of the elastin also means that we degrade those thin walls separating each alveolus. So this wall is called the alveolar septa. So let's imagine an alveolus and an alveolus. Because we are degrading the elastin, we're degrading that septa, the alveolar septa, the thin wall separating each alveolus from each other. So look what happens. Now what we've created is we've merged the two alveoli together. We've created a much larger space with less surface area. And what happens in alveoli? This is the site of gas exchange. So now we've just completely, you know, like decrease the surface area available for gas exchange because we're merging these alveoli together. And this happens in multiple alveoli in the acinus of the lung. So acinus is just like the terminal or the end of an airway where those alveoli are located. So in the acinus of the lung, we have the degradation of alveolar septa, meaning that those alveoli, they just merge into larger and larger and larger and larger surface area. Sorry, in larger and larger like blob, you know. So I just want to explain that again because I don't think I was being very, very clear. So in the acinus of the lung, which is the terminal or the end of an airway where our alveoli are located, and alveoli are our site of gas exchange. So because of the degradation and the loss of elastin, we degrade the alveolar septa, the thin wall separating each alveoli from each other. And because of that degradation, what happens is that each of the alveoli, they just merge into one big blob, into one big space. Instead of being individual alveoli, which increases the surface area for gas exchange, we just have a big merged like space, okay? So this significantly decreases the surface area for gas exchange. Another thing that happens is called hypoxemic vasoconstriction. So you know that there's this normal like autoregulatory mechanism of the lung that if we decrease ventilation to an alveoli, we decrease perfusion to that area as well, just to maintain our VQ ratio of 0.8. So VQ has to always equal 0.8. So our lungs, they respond by decreasing perfusion to certain areas with decreased ventilation. So this is fine if it happens in like a few alveoli and regions in the lung, but it becomes problematic if this is affecting multiple alveoli and multiple areas in the lung, because with that vasoconstriction of the vessel to limit the perfusion to that area, what we then develop is vasoconstriction of multiple vessels in the lung. This increases the pulmonary resistance. So this increases the resistance in the lungs. And this means that the right ventricle now then has to work so hard to push blood to that very, very high resistance area to the lungs. So the right ventricle then, as a result, hypertrophies, it gets bigger. and just to accommodate for the higher pressure in the lungs, and then eventually it can fail. So this can lead to right ventricular failure, and we actually call this cor pulmonale. So cor pulmonale is just right-sided failure due to a chronic lung condition. Now let's move on to the clinical features of chronic bronchitis and emphysema. So for chronic bronchitis, we usually use this phrase called blue bloaters. So I'll describe, and for emphysema, it's pink puffers. So blue bloaters, patients with chronic bronchitis, it's called blue bloaters. Bloaters because usually these patients are obese, and blue because they usually show cyanosis. Because of that very significant hypoxemia, that decreased oxygen in the blood, they can present with cyanosis. They can also have wheezing, especially on expiration, because it's harder for them to expel the air out, and therefore we might hear wheezing on expiration. We may also hear some inspiratory crackles in chronic bronchitis. Also, because of that loads of mucus being produced, we can see like productive cough in patients with chronic bronchitis. That's very important. Productive cough. Also, an increase in AP diameter, again because of the air trapping. We can also see like hyperresonance of the lungs on percussion. And finally, we can see dyspnea on exertion, again, partly because of that hypoxemic state that they're in. Moving on to emphysema. So these patients are usually called pink puffers. So puffer because they exhale through like pursed lips. So what this does is it actually prolongs the expiration. It helps them, just expel some of that air out and more CO2 out. And it's called pink puff. Usually they're pink. This refers to their skin tone and the level of oxygenation in the blood. So pink means because like in emphysema, we don't have a significant reduction in, especially in the early stages, we don't have a significant reduction in the O2 that we are inspiring, because during inspiration, those airways still remain patent. They still remain open. But during expiration, because of that loss in elastin, the airways collapse when the patients expire. So they develop significant hypercapnia, significant amounts of CO2 gets left inside the lung. So that causes hypercapnia. So as you can see, hypoxemia is not a significant problem, especially in the early stages, and therefore they remain pink because it's a sign that they can still properly oxygenate, especially during the early stages of the disease, okay? As opposed to the blue bloaters, patients with chronic bronchitis, it's because of that mucus plugging, it's really gonna limit the amount of oxygen they can take in, and therefore they develop cyanosis, okay? So with emphysema as well, we can see similar things. So an increase in AP diameter, again because of that air trapping. It's similar to chronic bronchitis. Another one that's similar is the hyperresonance of the lung upon percussion. Another symptom that's similar is wheezing. So in patients with emphysema, we can also hear wheezing on expiration when we auscultate, or when we hear these patients expire. One of the other, this is a difference now, because in emphysema, the patient tends to use a lot of accessory muscles. For breathing, we can see some weight loss in this patient as opposed to patients with chronic bronchitis, which are usually bigger patients, which are usually obese. I want to tell you guys that there's 3 different types of emphysema. So we have centrilobular or centriacinar, panacinar, and we have paraseptal or distal acinar emphysema. So with centrilobular or centriacinar emphysema, this is actually the most common type. So in this type, what we have is the destruction of the alveoli in the proximal and central part of the acinus, okay? And this is mostly associated with cigarette smoking because it's believed that the irritants from the smoke can't really get all the way to the distant alveoli of the acinus. So only the proximal and the central ones are affected. And centrilobular emphysema mostly affects the upper lobes of the lungs, okay? The second one is the panacinar emphysema. So in this type, what we have is the destruction or the whole, so basically all the alveoli in the acinus, they're all uniformly affected in this type. So this is mostly associated with that genetic condition, the deficiency in alpha-1 antitrypsin. So, and pan-acinar type usually affects the lower lobes of the lung. In the paraseptal or the distal acinar type, what we have is the destruction, or basically we affect the alveoli in the distal portion of the acinus. So basically this is very close to the periphery of the lungs near the pleura. And this is actually very dangerous because those balloon out alveoli, they can rupture and cause spontaneous pneumothorax. Now let's move on to the diagnosis. So for diagnosis, we usually take the history first, and that's going to give us a lot of clues as to whether this is a COPD case or not. So in terms of history, things that we're looking for is like obviously smoking history, or if the person is still a current smoker. If the person has worked or is working in a factory where the person is exposed to a lot of like dust, a lot of silica, a lot of air pollutants, if the patient has family history of COPD, and if the patient has like significant like liver problems, because recall that alpha-1 antitrypsin is produced by the liver. So if we damage the liver, then we may damage or impair the production of alpha-1 antitrypsin. Also, if they have any family history of an alpha-1 antitrypsin deficiency. The gold standard is doing pulmonary function tests. So the pulmonary function test will show us low FEV1 and low FVC. Right, just to remind you guys, FEV1 is forced expiratory volume in 1 second. So that's the amount of air that can be expelled in 1 second. And FVC is the amount of air that can be forcefully expired after taking like the deepest breath possible, after like maximal inspiration, like how much air can be forcefully expired. So that's FVC. So typically FEV1 is markedly low and FVC is low. So if we take a ratio of FEV1 over FVC, if that ratio is less than 75%, this is a positive diagnosis for COPD. Well, it's a positive diagnosis for any obstructive disease. It can be asthma because it's obstructive disease as well. But just to say that again, we will see low FEV1 and low FVC. And when we take the ratio FEV1 over FVC, if it's less than 75%, this points towards an obstructive disease. Okay, it can be COPD. Okay. Another thing that we will see is a high total lung capacity, high TLC. Because of that significant air trapping, you know, we expand, we dilate the lungs, so can take in more air, but air is just stuck there. The other one is high residual volume, an increase in residual volume. Residual volume is the amount of air that gets left behind after expiration. So because we have, again, a lot of air trapping and we're not really good at expelling that air out, a lot of that air gets trapped behind, increasing our residual volume. So these are the things that we will see in the pulmonary function test. So another thing we can add for the pulmonary test is the addition of a bronchodilator, like a SABA, so like albuterol, for example. So we can repeat the test after giving this patient like albuterol, like a SABA. And what this does is it makes the smooth muscles of the airway relax a bit. But unfortunately, in COPD, because the damage is irreversible, this wouldn't really improve the symptoms. So what we will see, if the patient has COPD, the FEV1 will not increase more than 12%. So the increase in FEV1 will be less than 12%. This points towards COPD. If after the addition of bronchodilator, FEV1 increases more than 12%, then this might be asthma. So this is one way of differentiating if it's COPD or if it's asthma. Other tests we can do to help us diagnose COPD can be just simply measuring their oxygen levels using like a SATS probe. So in chronic bronchitis patients, the oxygen will be low, and it will usually be less than 88% if we use a SATS probe. We can also take the arterial blood gases. So we can do an ABG. So that will show us hypercapnia and hypoxemia. So we're going to see high CO2 levels in the blood and low oxygen levels in the blood. And because we have higher partial pressure of CO2 in the blood, this means that, you know, remember that equation when CO2 becomes carbonic acid and then that dissociates to bicarb and a proton? Because we've increased CO2, we've increased carbonic acid, we've increased the protons. So we've made the blood more acidic. So in an arterial blood gas, we can also see decreased pH levels. So we can see respiratory acidosis. Another thing we can do is a chest x-ray. So this is, or maybe we can use a high resolution CT as well, which might be even better. So if we get a chest x-ray or a high res CT, we're gonna see the hyperinflation of the lung, so the expansion of the lung, and we may even see like a flattened diaphragm. And this is because of that significant air trapping. Lots more air is being trapped in the lung because they can't get out, so it's going to be hyperinflated. It's going to push the diaphragm down. Another thing we can see here is the increase in AP diameter, which is very classic in COPD patients, and it's again because of that significant air trapping. We can also order like a CBC, complete blood count, and this is non-specific really, but because of that hypoxemia, our kidneys react by producing more EPO to stimulate more red blood cell production. So this is like the body's way to compensate for the hypoxemia. Okay, it produces more red blood cells so that, you know, hopefully it can carry more oxygen, make it more perfusion to the tissues. So in a CBC, we can see a higher hematocrit levels. We can see polycythemia, but again, this is non-specific. Finally, we can get an ECG. This is not diagnostic of COPD, but it's just to let us rule out any other cardiac problems. It may also show us like multifocal atrial tachycardia during a COPD exacerbation, or like signs of right ventricular strain like T-wave inversions. Again, these are non-specific, and that right ventricular strain is because of that hypoxemic vasoconstriction. So because we're increasing the vasoconstriction in the lungs, because we've decreased ventilation, we try to decrease perfusion by vasoconstriction, therefore increasing the pressure in the lungs. So the right ventricle has to overcome higher pressure, so it becomes strained, and this can just manifest as like T-wave inversions in the ECG. But again, ECG is a non-diagnostic tool for COPD. It's just good to do to see if any of these are happening. Now let's talk about the treatment. So firstly, we need to advise them to stop smoking if they're still smoking at this stage, because as we said, smoking is the biggest contributor to COPD. The next one is more like prevention. So we need to give them influenza vaccine every year and pneumococcal vaccine. So this usually starts at the age of 65, but because these patients are really at high risk of getting such infections, we need to give this just for prevention. The next one is supplemental oxygen. So we give supplemental oxygen if the saturation is below 88%, or if the partial pressure of oxygen is below 55 millimeters of mercury. However, if, for example, we have a patient who has heart failure or high hematocrit when we do a CBC, then we can give supplemental oxygen even if their saturations is like less than 90% instead of less than 88%, or if their partial pressure of oxygen drops below 60 millimeters of mercury. Okay. And we give oxygen via nasal cannula so that we have better control, so that we can't give like a high flow or, 100% oxygen. We don't give 100% oxygen, and the reason for this is because we would take away that hypoxemic drive. So normally, when these patients they're hypoxemic, right? Because they're not taking in as much oxygen because of that mucus plugging. It's really narrowing that airway, making it difficult for the oxygen to come in. And what this does, this creates a hypoxemic drive. And this hypoxemia triggers the chemoreceptors in the carotid sinus. And when that gets triggered, saying, oh, we're in a hypoxic state, what it does is it stimulates the respiratory center in the medulla. And then that sends a message via the phrenic nerve and the intercostal nerve, I think, to stimulate the contraction of the diaphragm and the intercostal muscles, making our respirations faster and deeper. So this hypoxemic drive actually would help these patients be able to breathe more efficiently and better, okay? And if we give them 100% oxygen, then we take away this hypoxemic drive and we may put them in respiratory failure. The next type of treatment we can give these patients are bronchodilators. So these are our anticholinergics and our beta-2 agonists. So anticholinergics are your like SAMAs and LAMAs. So SAMA is short-acting muscarinic antagonist. For instance, ipratropium. We have the long-acting muscarinic antagonist, the LAMA. An example is tiotropium. And then we have our beta-2 agonist, including our SABAs and our LABAs. So SABA is short-acting beta-2 agonist, like albuterol. And LABAs are long-acting beta-2 agonist, like salmeterol. So for mild and like intermittent bouts of COPD, what we give the patient is a combination of SABA and SAMA, okay? Because they work really good in combination with each other. But if you had to pick one, it would be the anticholinergics. It would be your SAMAs. So to say that again, for mild COPD or intermittent, we give a combination of SABA and SAMA. And we can give this via a metered dose inhaler or via nebulizer. If we have a moderate to severe COPD, which is defined as FEV1 of less than 60%, then we can give a combination of LAMAs and LABAs. If we have a moderate to severe case of COPD and a combination of LABA and LAMA is not cutting it, we can use corticosteroids. We can use inhaled corticosteroids. So again, an indication for this is if LABA and LAMA is not working, we can give corticosteroids plus a LABA. We never give, by the way, we never give LABA on its own. It can actually worsen the symptoms. So you have to give LABA with a LAMA or a corticosteroid. And the way that corticosteroids work is that they inhibit the release of cytokines, and therefore they inhibit the activation of white blood cells and the chemotaxis of these white blood cells to the site of inflammation. Also, we can give corticosteroids if we have like an acute exacerbation of COPD, either IV or orally, but this should not be used for a long time. This is only reserved for acute exacerbation, not for chronic use, because it has a lot of really negative systemic side effects. Another drug we can give these patients is a phosphodiesterase inhibitor like theophylline, for example. And this is reserved for patients with really severe exacerbation of their COPD who needs diaphragmatic rest. So the way this works is that they relax those smooth muscles in the airway, giving the person diaphragmatic rest. And this is usually never given on its own. The other one we need to do is we need to make sure that they have long-term antibiotic therapy. We give them azithromycin, which is a macrolide, and it has anti-inflammatory effects, which is going to help with their COPD.